An EKG, the only thing it does is measures the electroconductivity of the heart. So, you can have a patient come in, we do an EKG, and it could be perfect. And later that evening, they could have a heart attack. Okay, because it only measures the electroconductivity at that time. So it's a graphic record of the heart's electrical activity, its conduction of impulses, and a record of electrical events that precede the contractions of the heart. So production of electrocardiogram, has everyone done one in here? Kind of? No?
Know what it is?
No, have you ever done one on patient? Yeah. Okay. I don't have any here, but they do in the MA department, and they should have some in the nursing. I'm gonna have to check with them. I have some at my office I could bring in if you guys want practice. So the production of the ECG, electrodes are attached to the subject. Voltage changes that represent the heart's electrical activity are sensed by electrodes and recorded on paper. So, the composition of ECG waves of a normal recording, okay? This is when the heart, of course, is, there's no pathologies going on. I want you to know what happens in each wave. So let's look at it. In the P wave, it represents depolarization of the atrium. Depolarization. Do you remember what depolarization means? We talked about it when we talked about action potentials. If something is depolarized, what do I mean by that? It's engaged, it's contracting, it's active.
And it's repolarization.
Repolarization is relaxing, right? So depolarization, I want you to think that the atria is engaged, it's contracting. Depolarization. Are we okay with that one? So for the P wave, you're going to tell me that the function is that the atria is contracting or depolarized. It's engaged. That's what the P wave represents. Depolarization of the atrium. Now the QRS complex is next. So we have the P wave first, and then we have the QRS complex. It represents depolarization of the ventricles. So now the ventricles are depolarized, and the atria is repolarizing, it's relaxing. Remember I told you they don't do both at the same time, right? If one's contracting, the other one's relaxing. The T wave is next. That's the third wave you're going to see. And it represents repolarization of the ventricles. So now your ventricles are starting to relax. It's really easy if you think P wave, depolarization of the atria. QRS complex, now the atria is repolarizing, they're relaxing, and the ventricles are contracting or depolarized. T wave, now the ventricles are going to start relaxing or repolarizing. So at the end of the T wave, sometimes we can see a real tiny U wave. Sometimes we don't even see it at all, which is good. We really don't want to see a U wave, and if we do, if it's really small, it's okay. But if we see a substantial U wave, I'm going to tell you what it's indicative of. It means that your patient is suffering from hypokalemia, which is what? Low what?
Calcium.
Low potassium. Low potassium, kalemia. Calcium is calcemia. Yeah. Okay, low potassium, hypocalcemia. I promise you, you're gonna see this in court, and I promise, I would bet my life that it's gonna be on your NCLEX. I know it will, right? So whenever they start talking about a U wave on a test, right away I want you to think hypokalemia, low potassium. And or, here's the other thing that could be going on. Your patient is suffering from digitalis or digoxin toxicity. Digitalis or digoxin toxicity. What is digoxin? It's a drug, it's a medication that we give our patients. We use it to treat congestive heart failure. We use it to treat pulmonary hypertension. Okay, it's a great drug for those two things especially.
If you said that, if that's the, if the U wave substantial again?
If the U wave is substantial, it's because of hypocalcemia, low potassium, and digitalis toxicity. But here's the thing about digitalis or digoxin. It's derived from a plant called foxglove. And back in the day, we used to take that foxglove, well, I didn't, but people did, to kill their spouse because it was a poison. Right? And this is what this medication is derived from. So if the patient has too much, it can cause a serious problem, right? Especially with their heart, right? So they're the two things. When you see a substantial U wave, you're thinking hypokalemia and or a digitalis toxicity. And you'll know if it's digitalis toxicity because if you look at their chart and they're taking it, if they're taking digoxin, then you think, okay, this is why I see that U wave. And they're probably suffering from low potassium too. And low potassium can cause cardiac issues just like high potassium, hyperkalemia, except it's worse with hyperkalemia. If you have your blood work done and your potassium's high, they're gonna be calling you and saying, get back in here right away. It's urgent, and what they'll do is do the blood work again. And if it's still high, they'll probably hit you because they've gotta get that potassium down. And we'll talk about the different reasons that potassium can be high. Your diabetic patients, if they're not taking a diuretic, they usually will suffer from high potassium. What's the other real big one that can cause high potassium? Eating disorders like anorexia and things like that. Their potassium levels tend to be sky high. And in the end, that's what really causes their death. We can't get that potassium down. Absence of or small U waves are considered normal. However, if they're substantial, it's a sign of hypokalemia or too much digoxin. Digoxin, digitalis is the same thing. EKG intervals between the P, QRS, and T waves can provide information about the rate of conduction of an action potential through the heart. Just know though, guys, if your patient comes in with chest pain, right, and you do the EKG and it's normal, we're not gonna go by that, right? Because we have already ordered blood work. And if that, do you remember what we're looking for? What cardiac enzyme? A troponin. So if the troponin's high, it's indicative that that patient definitely had some cardiac event. regardless of what the EKG says. So on slide 35, you might want to print this out. It's an excellent visual of what you're looking at on an EKG. So in step 1, the heart wall is completely relaxed. So you're just going to see a straight line here. That's how it starts out. Okay? Then you come over here, and this blue represents the P wave. What's happening in the P wave? The atria are depolarizing. And in this picture, yellow is for depolarization and orange is for repolarization. So here's your P wave. Now in step 3, nothing else is going on except the atria is even becoming more depolarized. So you're gonna have that straight line again, right? Because nothing else is happening other than the atria is now fully depolarized. And then we come over here, and here's our QRS complex. So what's happening with the atria? The orange is coming in, right? So the atria is relaxing or repolarizing, and what's happening to our ventricles? They're depolarizing now. So there's your QRS. Now we come over here, and there's no change, so we have this straight line, right? Because all is happening is that now the ventricles are completely depolarized. And then we come over here, and we have our T wave. What's happening in the T wave? Well, the ventricles are starting to repolarize or relax. And we come over to step 7, and no change, because all that's happening now is that the ventricles are completely relaxed or repolarized. So you got your straight line there. Are we good? Okay, here's your little U wave that I was talking about. So for the test, what do you want to know about the U wave? If it's present, it's always after the T wave. Okay, I want you to know that. And then, what is it indicative of if we have a U wave that looks like that? Hypokalemia and digitalis toxicity or digoxin toxicity. Excellent. Okay. We're good? Okay. Let's start with 38. And we're going to talk about the cardiac cycle. So when we take a blood pressure, what's the top number called? Systolic. What's the bottom number called? Diastolic. Diastolic. What should the top number be?
80.
About 120, right? What should the bottom number, diastolic, what should that be?
80.
About 80. I will tell you though, if a patient's had a heart attack, the cardiologist probably will not be happy with 120 over 80, even though it's normal. They're gonna want it a little lower than that. Okay. Otherwise, the standard is 120 over 80. The cardiac cycle is often divided into time intervals. I wanted to share with you that a few years ago, I went to a cardio conference, and it was mainly about cardiac issues in the elderly. And what they have discovered is that when people are in chronic pain, their systolic number tends to be high. So, and of course, unfortunately, our elderly are usually in pain, right, from arthritis, or different things. So their blood pressure will usually read like 150 over 70 or 150 over 80. What we're trying to do now, instead of putting them on blood pressure medication, is to try to control the pain. Because if we can control the pain, we find that that systolic number goes down. So, the other thing I want to mention regarding blood pressure in general is that if you're sleep deprived, it can make your blood pressure spike. Okay, that's another reason why we should look at the sleep issues of our patients. Not only does sleep deprivation cause the blood pressure to spike, it also causes depression. And if we can treat the sleep issue before we put our patients on antidepressants, it's much healthier for them. Okay, so we already know, begins with the P wave on the EKG, which triggers atrial contraction. Contraction of the atria creates a pressure gradient that pushes blood out of the atria and into the relaxed ventricles. Because of pressure gradients, the AV valves are open, the SL or semilunar valves are closed. Ventricles are relaxed and filling with blood from the atria. So, I want you to put in your notes that the first heart sound is caused by the ventricles contracting. The first heart sound is caused by those ventricles contracting. And how many of you have taken manual blood pressures? They're kind of the thing of the past. Okay. So it's pretty easy to hear that first number, right? Second number is not so easy. And I want you to know that the second number, or the diastolic number, is caused when the semilunar valves snap shut. And that's why it's so abrupt, right? And that's the sound that you hear. But again, sometimes it's more difficult to hear than the systolic. So a considerable amount of blood, called the residual volume, normally remains in the ventricles at the end of the ejection period. In heart failure, the residual volume in the ventricles may greatly exceed the amount of blood ejected during systole. So what's happening to that blood? Instead of it leaving the ventricle and going out through the aorta and being pumped systemically throughout the rest of the body, what's happening to most of it? It's staying in the ventricles. So I'm going to go back to this, but I want to show you something. This is congestive heart failure. Look at it. This is normal heart with congestive heart failure, and this happens over time, right? It's kind of like a progression. But all that blood accumulates, and instead of it flowing like it should, you're not getting enough blood that's being pumped systemically through the rest of the body. Okay. So what happens with a patient with congestive heart failure? Their heart's not pumping the way it should. It's pumping like this, real slow. Right? So how are they going to present? If you have a patient with congestive heart failure, how are they going to come in? Yeah, so they're going to be short of breath, right? They're going to have shortness of breath. And I mean shortness of breath just taking a few steps, right? What do you think their feet ankles are going to look like? They're going to be swollen. More often than not, they're not wearing real shoes, or they're wearing slippers or something like that because they can't fit into any of their shoes. That's how swollen they are. So if you have a patient that has congestive heart failure, and you guys guys, as nurses, what are you gonna be doing? You're going to be teaching, educating. So let's say I'm your new patient and I have congestive heart failure. What are you gonna tell me not to do? Yes, not to eat salt.
What is it, like 1,200 a day?
That's very, very, so here's my next step. I'm going to say, oh, honey, I never eat salt. I never salt anything. And then your question's going to be, well, what do you eat? And I'm gonna say, I eat TV dinners every day because I live by myself.
There's a lot of salt. It's very nice.
One TV dinner is probably enough for a week, especially with a person that has congestive heart failure. So you have to explain that to them. I know it sounds silly, but they really don't correlate all the fluid that is around their feet and ankles with having all that fluid around their heart and lungs. And that's why they're short of breath. So you have to explain it in a very kind way, but you have to explain it to them so that they can make that correlation, right? Because someone with congestive heart failure can live a long time. It's not like a death sentence like you're gonna die tomorrow. They can live a while, but they have to change their lifestyle.
Does that also depend on what stage they are?
Oh, well, yeah, absolutely, absolutely. Oh, of course, yes, absolutely. But, you know, like I said, you know, if we catch it early and have proper medication, what are we gonna give for the fluid? With congestive heart Lasix, so we can drain that fluid. What happens if they have kidney issues? Because remember, what does the diuretic do? What does Lasix do? It makes you pee, right? It makes you urinate, and that's real harsh on the kidneys. So now your patient has a double whammy. Their kidneys are failing, right? And they have congestive heart failure. But here's, as a nurse, here's what you're looking at. Well, at this particular time, right now, the congestive heart failure is more of a concern than the kidneys. So even though, you know, we're gonna give them the Lasix, it's gonna help with the heart, and that's the priority right now, right? But it is going to be very harsh on the kidneys that are already struggling.
Is it like, it's like my brother's sister, he has TCHF stage 3, and he's also, one kidney works like 25% of the time, the other one's like 60%. So these are bad kidneys. So with this, I know that they have to do a low dose like 6, and then they switch them off, and get it instead. And then they switch it back every few months. Is it what you
Yeah, that's what they, yeah, because you're trying to balance both two horrible conditions, right? And you're trying to balance them both. One thing, as far as potassium goes, remember I said with diabetic patients, the potassium tends to be high? Well, if they've got kidney issues, and if their potassium is only like 5.1, 5.2, what I do instead of putting them on a diuretic, I give them calcium. And it's really cool because the calcium will bind to the potassium and it draws it out naturally. And it's not harsh on the kidneys. So I will do that when I'm trying to control the calcium. If it's not too high, obviously if it's 5.8 or 6, we gotta use the diuretics to get that calcium down as quick as possible. Okay. So I think AV valves do not open until the pressure in the atrial chambers increases above that in the relaxing ventricles. And I've already told you about the second heart sound. The diastolic is when those semi-lunar valves stop shut. So you want to know that. Okay, and we've already talked about the systolic sound. It's when the ventricles are contracting. Heart sounds are clinically significant because they provide information about the functioning of the valves of the heart. And wanna know all the disorders, all the pathologies for the quiz. Disorders involving the heart valve, we can have stress valves, narrow valves, that's slow blood flow. Rheumatic heart disease results from a delayed inflammatory response to the strep infection. Mitral valve prolapse, you already know what the mitral valve does now, right? So if it's prolapsed, we're in trouble, right? It affects the bicuspid or mitral valves. Disorders involving the myocardium, coronary artery disease, it's huge here. Myocardial infarction, which is a heart attack. What's angina? Yeah, chest pain. What do we use to treat it? Nitroglycerin. Yeah, nitroglycerin.
It's kind of funny.
So in both coronary thrombosis and coronary embolism, a blood clot occludes or plugs some part of the coronary artery. Blood cannot pass through the occluded vessel, and so cannot reach the heart muscle cells it normally supplies. Deprived of oxygen, these cells soon die or are damaged. In medical terms, a myocardial infarction or tissue death occurs. So you want to keep in your mind that every time someone has a heart attack, and they can have a heart attack and not even know it, right? But how do we know 10 years later that they had a heart attack 10 years prior? They have scar tissue, right? So even though they didn't know they had a heart attack, it still damaged the heart. But it damaged a part of the heart where it basically went unnoticed. Cardiomyopathy is a disease that results from an abnormal heart enlargement, which is called cardiomegaly. Disorders of heart function, you're gonna see this a lot, dysrhythmias, blocked AV node. What's the AV node called? No, gatekeeper. Results in slower ventricular contractions. Atrial fib occurs commonly in mitral stenosis, rheumatic heart disease, and infarction of the atrial myocardium. So heart failure is the inability of the heart to pump enough blood to sustain life. Congestive heart failure, the inability of the left ventricle to pump blood effectively. And that's what we see here. And you already know bradycardia, anything below 60. Tachycardia is anything above 100. And left-sided heart failure also causes congestion of blood in the pulmonary circulation, which we refer to as pulmonary edema. Okay. So with congestive heart failure, eventually they're gonna, how did they die, basically? In layman's terms, what do we say? Yeah, they drowned in their own fluid, basically. Okay, guys, any questions at all? So, chapter 21 is like very short, 8 or 9 slides. I did this starting last semester, and I'm gonna continue this semester. Miss Kitty's going to go over that with you. So she told me not to worry about it in here, so I'm not. Okay. So you will be tested on that. So next week, we're going to do 22, which is the lymphatic system. Any questions at all? No? Okay, so as far as the review goes, this should all be fresh in your mind, right? you wanna know what happened